Welcome to Mission Evolution Radio Show with Gwilda Wiyaka, bringing together today's leading experts to uncover ever-deepening spiritual truths and the latest scientific developments in support of the evolution of humankind. For more information on Mission Evolution Radio with Gwilda Wiyaka, visit www.missionevolution.org. And now, here's the host of Mission Evolution, Miss Gwilda Wiyaka.
Are you sick and tired of being sick and tired? Do you chase symptoms around without finding any relief? Is it possible that hormonal imbalances are involved? This is the first in a set of three episodes addressing the very important issue of hormonal imbalances for both men and women, what may be causing them, and what can be done about them. Mission Evolution Radio TV show is coming to you around the world on the Voice of Canada Broadcast Network, www.vocbn.ca. With us this hour to explore the devastating effects of hormonal imbalances is Dr. Aimee Duffy. Dr. Duffy is a renowned expert in functional hormonal health. She began her medical career as a board-certified family practice physician, treating a broad range of patients, including pediatrics, geriatrics, and women's health. In 2007, Dr. Duffy joined a thriving obstetrics gynecological practice, after which she began focusing on hormonal imbalances, thyroid dysfunction, adrenal fatigue, and weight management. In 2011, Dr. Duffy opened Carolina Integrative Medicine, a practice dedicated to whole person wellness. She's the #1 best-selling author of Normal Doesn't Have Side Effects and Why She Can't See Me. Her website, carolinaintegrativemedicine.com. Dr. Duffy, thank you so much for joining us on Mission Evolution.
Thank you. I'm super excited to be here.
Oh, this is such a great topic. So you started out as a family practice physician. What inspired you to focus on women's health and functional medicine?
Well, it goes even back farther than that. When I was a little girl, I just absolutely loved babies. They were my favorite thing, and I wanted to hold all the babies and squeeze their chubby cheeks. And so I became a babysitter at the age of 11. And that family had 2 kids of their own, and then the sister of that mom also had kids. And so I was just sort of the family babysitter of the whole thing. And I just got to play with babies all the time. It was awesome. So when I was in high school, the sister was having another baby and invited me to be in the delivery room. So I got to experience firsthand, where babies came from, basically. And that moment really kind of sealed the deal that I loved babies, but I really liked the idea of being part of that delivery room experience. So I wanted to go do OBGYN and be an OB doctor. But I also I wanted to see the babies too, so I had this balance. And so when I found that family practice was an opportunity for you to do both things, and, the times are changing a little bit, but I still think there are some family practice doctors that are delivering babies. So I decided to do family practice. I wanted to have a family of my own. I had baby number 1 in 3rd year of medical school. And so I knew that I needed a lifestyle that was going to help me, sort of be able to be a mom too. And so I chose family practice, and I chose a residency that was rather strong in obstetrics. And so that got me on that path to women's health and delivering babies. And then I just lucked out that I'm in a small town, in the OBGYN group next door, basically, had lost a provider to move to another state. And so they offered me a job to work directly with them to do primary care for the women in the OBGYN practice, but then also cover the OB call with them. So I just dove, head into a full-blown women's health experience rather than just that being part of my patient load. And I really felt inadequate to some degree at the immensity of the women's health world and the problems. It wasn't just come in for your annual pap smear or, for the baby delivering part. And the symptoms that the women were dealing with, sleep issues, the fatigue, the stress and mood type stuff we were dealing with. And interestingly, Lexapro is the #2 prescribed medication in the country for women, particularly around the age of 40 to 60. So, something's going on there. And I just felt really inadequate, and then had, several patients that were either coming in needing to deal with some hormone related symptoms of menopause with hot flashes or the irritability, or women that were already on these hormones, and we're getting this message around that time. This was 20-25 years ago, that hormones were bad and we shouldn't do that, or we should just do the lowest dose possible for the smallest period of time, right? And that didn't sit well with me. I thought, well, surely there's got to be another way. And so I sort of did some searching and happened upon natural hormone balancing and the world of what we call bioidentical hormone replacement. And it really was just an eye opener. I mean, I felt like Alice in Wonderland going through that tiny little door into this like amazing world of this functional and integrative space. We're really looking at the imbalances that are going on and the dysfunction. And if we can start to correct those imbalances, then we just see amazing results without using, prescription medications.
So, what is Lexapro? Just so we're all on the same page.
So Lexapro is an antidepressant. It's an SSRI.
Okay.
So, um,
Right. So instead of balancing the hormones, they just deal
yeah,
with the
they Band-Aid
depression.
it.
Yeah. Yeah.
So you
Okay.
get
I
put on birth
understand.
control pills, you get put on, some sort of antidepressant medicine, sleeping pills, sometimes even Adderall for giving you that boost of energy or that, focus and mindset. I think my kids are being diagnosed with ADD and I have all the same symptoms that my kids have. So, is this adult onset ADD, or can I get the same medication that my kid is on, kind of thing? And, women in that age range of, late 30s, early 40s, we're seeing a lot of those symptoms. And I think it's directly hormone adrenal dysfunction related.
Why are we seeing so much hormonal adrenal dysfunction at this time in the world in general?
I think stress. I just presented on adrenal fatigue, and that was really the big picture for me was, our bodies are really designed to protect us, to keep us alive, and we're in survival mode first, and then we want to stay healthy, and then we want to find joy, right? And so um when our body is feeling under constant stress, we're constantly being chased by a lion, we use a lot of cortisol or adrenaline, if you want to call it, and that's kicking out a whole bunch. Our brain is sensing we need to do something, we need to be, running from this lion. And so we have high cortisol initially, but then over time, I call that the marathon of life. We're sprinting all the time uphill and we never really take a break. And so eventually your adrenals just weren't designed to kick out that much cortisol all the time over and over again. So cortisol levels actually go down. Well, survival in the caveman world, if you want to think about it, our innate survival is more important than procreation. So it actually pulls our progesterone. It sort of sacrifices your progesterone to keep cortisol levels stable so that we can survive that lion or tiger that's chasing us. So in women prior to menopause, that's generally what I see is whatever hormonal imbalances they may have, it's generally coming from the cortisol imbalances and the adrenal fatigue as opposed to some other underlying hormone dysfunction.
So let me see if I got this right. The adrenals make the start making this stuff up originally, but
Correct.
then they get burnt out, and then it shifts to the sex hormones to fill in the gap.
No, it's the opposite. So it wants to keep cortisol high, and so it
Hmm.
actually pulls progesterone to convert over to cortisol. And so you get a low progesterone level, and so low progesterone symptoms feel like you're PMSing all the time. So you're irritable, you're moody, you might have irregular period, you're not sleeping well. Progesterone is very calming to our brain, so that's leading to hormonal imbalances because of the adrenal dysfunction. And the adrenal dysfunction is because of the stress that we're dealing with. And stress doesn't always have to be negative stress, but we're overstimulated, right? I mean, we have things that are sending the signal to our brain that we need more cortisol. So we're setting the alarm before the sun comes up. So we're waking up early in the morning. That's telling our bodies it's time to get up before naturally we would have woken up. Then the sun goes down and we're turning all these lights on. We've got our phones in front of us. We've got screens. We've got lights turned on. So just the day has become longer. And so just that in and of itself, over a long period of time, can tell our brain, it's our brains are asking for more cortisol than what was typically designed. And then on top of that, you have stimulation of driving in traffic or or just the meetings you got to get to, the phone notifications bleeping at you all the time, like all that little stuff is just that little bit of extra stimulation. And then if you add major stressors, whether that's work related, finance stress, relationship stress, taking care of your kids and running around all over the place, then we have internal stressors. So if you're dealing with some chronic illness, some gut stuff, we know that there's a significant gut-brain connection. So you may not even recognize that sometimes the foods you're eating, your body has to go, what is this? What are we going to do? And again, your body's job is to protect you. So it's going to hide it. You may not have a symptom necessarily. It's just going to say, oh, we got to take care of that. And so it's happening in the background and on the sidelines, and you may not even notice. So this chronic sort of stimulation all the time initially may present with high cortisol, but usually people aren't coming to see me when their cortisol is high because they're adapted to that. They're doing great. It's when their cortisol levels go down because their adrenals are like, we can't keep doing this sprinting all the time. And so you start to get fatigued there.
So it's the same for men and women, is that correct?
Yes.
Yeah. Yeah. So we're definitely hitting it from
So
both
it'll
ends.
pull testosterone, we'll see low, hormones in general. I'm just using progesterone as an example, but we'll see lower hormones than expected, in women prior to 50, which is typically the menopause age where we know hormones start to decline. But in that what we call perimenopause, which is kind of like the 10 years before menopause, we'll start to see some hormone changes there. And men, their testosterone level, if you want to call it, naturally declines around the time at age 50, but we may see males in their early 40s or even late 30s with low testosterone. And again, you might go, why is this happening? That's not physiologically normal. And it's generally because of the adrenal dysfunction that it's changing the hormones.
So how much does diet have to do with it? I mean, we're grabbing things on the run, and so we never sit down and enjoy a meal,
Right.
much less digest it.
Exactly. Yeah. So it's a combination of eating behaviors, right? So driving on the run and eating on the run. We don't slow down. We don't stop. We get into that, what we call parasympathetic, where you're in rest, digest, and recover mode. If we're in sympathetic and we're in a hurry all the time, then one, you're not going to digest your food very much. Also, we tend to eat more. And that's because you're not going slow. And if you sit down and, this happens all the time, I go have a meal with a friend or a colleague or something, and you're like halfway through the meal and you only ate part of it, but you're full because you spent so much time talking. And so if you give yourself some time, you're actually going to eat less food than if you're in a hurry and you're kind of shoving everything in. And then you go, oh, why did I do that? I feel bloated and gross now, right? So it's a combination of our behaviors around eating, but it's also what we're eating. So, I mean, we are 100% bombarded with food that isn't really food. The amount of processed and chemicals and things, we hear this all the time. I mean, just in the food that, even if we think that we're eating something healthy, it says natural on it or it says organic on it, but it's still, just full of preservatives, full of chemicals. And those are all stressors that our system has to go, who are you, and are you a good guy or a bad guy? So just the thought process of having to figure it out
is another
versus,
stressor.
I just ate an apple.
We're going to have to take a station break.
Okay.
Dr. Duffy and I will return very shortly, so don't go away. This is Mission Evolution, www.missionevolution.org. Am I going nuts, or is it my hormones? With us this hour exploring hormonal health is Dr. Aimee Duffy, the author of Normal Doesn't Have Side Effects. Her website, carolinaintegrativemedicine.com. Amy, we were talking about food and food choices and the way we eat it and all that as contributing to our stress, which
Yes.
contributes to our hormonal imbalances. It seems like there's a lot of contributors to hormonal imbalance that doesn't have to do with supplementing with hormones. So, can we talk about root cause a little bit there?
Absolutely. I mean, again, we were diving into, food, particularly in diet, how we eat, in terms of being on the run, eating in the car. It's hard to eat, vegetables and have a knife where you're cutting your protein, or you're cutting up a piece of asparagus when you're driving in your car, right? So we tend to do the handheld stuff, the quick grab and go snacks. And again, those things are just full of chemicals. And even if you don't feel it, and I think that's what throws people off so much is there's not a direct, people think about food intolerance as being like, oh, I get a rash, or I get, swollen, or I get a stomach discomfort after I eat something. And so, again, your body's job is to protect you. So it may not necessarily send you a signal, although it should, if it's something really bad. But if it's just sort of a minor, oh, this is stressful, I'm just going to go put it off to the side, you may not notice. We also can see signs that are delayed a little bit. So not a typical immediate response to the food, but the next morning you've got a headache, or your hands are swollen, or you feel a little bit more inflamed, or you got some bloating later in the evening or the afternoon, and that could be a sign of something that you ate earlier that you're not really putting two and two together.
So
So
how does that then equate with a hormonal imbalance?
So again, going back to there's two things that we can talk about there, is that if your body is trying to deal with those things and it's sending a signal, that's sort of a stress response. Oh, this is something we have to worry about, we have to deal with. And so there's a stress response there that leads to further adrenal dysfunction, like we talked about. And and then the adrenals, because I'm sort of describing, they're kind of at the bottom of the chain, if you want to think about it, but they're really important. Like, we have to have our cortisol in order to survive, to be able to run from the tiger that might be chasing us, or, get through a scary experience. And so in order to maintain cortisol, because it's being dragged down by other things, our body's going to sort of sacrifice our hormones. So hormones are going to be pulled down with it in order to maintain that cortisol level. So we'll see hormonal imbalances that way. The other way that food can change our hormones is that food can have hormones in it. So particularly like dairy. So dairy is injected with a lot of different hormones. Dairy cows are injected with hormones in order to make more milk, right? And we're being exposed to those hormones all the time. So those can alter our own hormones, as well as a lot of processed foods and chemicals have hormone disruptors in them, we call them. So they kind of sit in the receptor site, particularly for estrogen. Plastics do a lot of that as well. So we call them xenoestrogens, where they're like just close enough to looking like estrogen that your body thinks it's an estrogen, but it doesn't really do what estrogen does. So it will sit in that receptor site and not let estrogen get in and do its job. So it's sort of a big bully sitting in the way, if you want to think about it. And so estrogen goes, oh, you're already there, I don't need to do anything, and it runs away. So we can see hormonal imbalances just from the chemicals that we're being exposed to.
So for us lay people, what's a receptor site?
It's sort of like, you're right. Lay people, I have to remember. I just did a presentation to other practitioners like 2 days ago, so my brain is in that mode. So what happens is kind of like a key into a socket, right? So we have all these doorknobs, if you want to think about it, all these doors that are all lined up inside of our tissues and inside of our cells. And there's special keys that go into all those doorknobs. So estrogen, for instance, is a key, or cortisol is a key, or progesterone is a key that can open or close that door. And so let's say that you have this plastic fake key, almost like the plugs that we put into the outlets to keep babies from, sticking their hands in them. That's a plug that fits inside that keyhole, but it's not doing anything. It's not stimulating, or that key, if you put a plastic key in there just to hold the space, but the key can't actually turn and do anything. Does that make sense?
Absolutely.
So something can sit in that hole, in that keyhole, or in the plug outlet, and not do anything. And that can cause an imbalance in your hormones as well.
What's the most common hormonal imbalance with women and then with men?
To me, progesterone deficiency is probably the most common that I see, and it can happen really early on. I mean, we can see it in early 20s in women that have something called PCOS or polycystic ovarian syndrome. That can be connected with irregular cycles and some insulin resistance or weight, blood sugar imbalances, some acne, things like that. So we can see hormonal imbalances like that as early as in the 20s for women, and that's generally a progesterone deficient state. And then that can either lead to, or you might see low progesterone in somebody trying to get pregnant. So infertility is also a very low progesterone state. Again, usually related to some stressors, and whether that's external stressors or internal stressors. If you had a lot of allergies and gut related stuff when you were younger, you might have some hormonal imbalances there. So women, you can see progesterone really early on, and it just sort of continues. Progesterone starts to decline up to 10 years before estrogen declines in the menopause sort of phases, if you want to call it. So progesterone's already gone long before you might have lack of menstrual cycles that you would see as part of menopause. So I would say progesterone is the big gun there. And then of course, we're going to see other hormonal imbalances or changes, if you want to call it, as we go through menopause. All the hormones go away, basically. So we see low progesterone, low estrogen, low testosterone. Cortisol may or may not follow that. So those are the main ones that we might see in women. In men, typically testosterone is the thing that we're looking at, because testosterone is supposed to be higher in men. Well, it is higher in men, for procreation purposes, but also it continues to stay elevated, and it will start to decline in the 40s. And then, men go through what we call menopause or andropause, which is where testosterone levels decline as well. So probably testosterone is the most common. However, we will see that low cortisol in men as well.
So, speaking of men and testosterone, there's the word on the street is, if you take supplemental testosterone, you're running a risk of having a heart attack and all sorts of nasty stuff.
Mm.
Is that true, or are we looking at a myth?
No, so opposite. And I think, interestingly, that study, if you want to call it a study, but that phenomenon was reported by the Wall Street Journal, which is not a medical journal. And I don't know what the reasoning behind that was, but basically they did an evaluation or an observation, if you want to call it that. There was like 60% of men that were in the cardiac ICU having had a heart attack were on testosterone replacement. So then they just decided that testosterone caused the cardiac dysfunction, which is so not true. And in fact, there are so many studies now that show us that low testosterone has a significantly higher risk for cardiovascular event, as well as all-cause mortality in men over the age of 50. So testosterone is not just about bulking up. It's not just about, treating maybe some low libido as you're aging, but it is really cardiovascular preventative. Testosterone is a very strong anti-inflammatory at the level of the inside lining of the blood vessels of your arteries is called the endothelium. And that has doorknobs, if you want to call it, or outlets for testosterone on there. And so when testosterone hits and stimulates that, it actually decreases inflammation and it helps open up blood flow. So testosterone is actually the opposite. It's very important for cardiovascular health, particularly in men, although we also see that in women. So testosterone
So
replacement in women is really important too,
we wouldn't think of a woman and testosterone, but I guess
right?
we need it, right?
Just
So
different levels. Yeah.
you're talking about it being a natural anti-inflammatory. Cancer is an inflammatory disease. What about prostate cancer and various cancers as they relate to testosterone levels?
Great question. So, I think there's a couple different thought processes there. Is testosterone can convert to estrogen, and estrogen at high levels can stimulate prostate tissue to grow. There's not been any actual studies that link testosterone and or estrogen to prostate cancer directly, but there is some connection there. So we have to make sure that we're monitoring it. And I think what happened for a lot of people is they measured testosterone, it was low, so we're going to do testosterone replacement, and then they just went by symptoms and they didn't really follow up on treatment. So you can get over testosteronized, if you want to call it, and that can lead to some prostate growth. So, you want to make sure that if you are getting testosterone replacement, that it's being measured appropriately. And in my case, for my patients, I do saliva testing for hormones. So I can see the actual free levels of hormones that all of your tissues are being exposed to, number one. Number two, in men, I measure all the hormones just like I do in women. So I'm watching that estrogen level. I'm watching progesterone. Progesterone can be protective to the prostate. So it'll sit in there and block in a good way so that there's not extra stimulation to the prostate. So we measure the whole thing and make sure that we're watching that. So we get testosterone levels in our happy zone, but we're also making sure that it's not converting to estrogen, and we keep estrogen levels nice and low.
So, in other words, you can't trust how you're feeling, particularly.
Yeah. So the other thing that happens is you live in a very dry climate. So I'm gonna think about that. Like, let's say you get rain, and I don't know if this exists because you might not get rain there, but it's dry, dry, dry. We're in this drought, and then you get this whole bunch of rain. And instead of getting a little bit of rain over a while that will nicely saturate and provide some moisture, if you get dumped with a whole bunch of rain all at one time, the term we use is called saturated. So you're going to get puddles, you're going to get flooding. And so if we dump a whole bunch of hormones all at one time, you may see some positive results initially, but over time that can saturate the tissues with too much, and then you're not feeling it anymore. And so, you see this all the time in people that are doing high doses of hormone replacement, that they'll be like, man, when I first started testosterone, I felt amazing. It was perfect. And then like a year later, it seemed like it wasn't doing what it did in the beginning. And so you naturally, from a subjective perspective, you want to increase the dose because you think, oh, well, I need to go up on it. When technically speaking, you might want to back off or take some space away from that, because too much can feel, there's sort of this interesting curve of, I feel good as my levels are going up, and then there's sort of this happy place. And then if you increase the dose, you can actually go backwards and start to see some low hormone symptoms with high levels. So monitoring the levels is really important. You can't just go by how you feel.
That makes perfect sense, doesn't it? When you explained it that way, yeah, it's amazing. So you get to a sweet spot, and then if you continue, then it throws you into an imbalance. Well, either one is an imbalance, right?
Right.
Okay.
And you might be able to continue that way, but sometimes we'll have prescriptions where we say do it every day and leave it off on Sundays, or take a week off every so often, that kind of thing. And that's the whole point of kind of resetting the system and sort of getting it out of your system a little bit, so you're not oversaturating.
We're going to have to take a station break. Dr. Duffy and I will be right back. Stay right there. This is Mission Evolution, www.missionevolution.org. Why does menopause have such a bad rap? This is Mission Evolution, missionevolution.org. With us discussing menopausal myths is Dr. Aimee Duffy. Her website, carolinaintegrativemedicine.com. So there's the question of the day. All women go through menopause. Why is it such a trauma? Was it designed that way?
It's interesting because I hear about this all the time. It's kind of like, well, isn't menopause natural, right? And shouldn't we just let nature take its course? And when you think about sort of caveman days, like you live, you procreate, and then you're done. And so, we didn't live much past the 40s until we kind of got smart and figured out how to live longer. So hormones initially are there just for procreation and survival of the species, right? And once we figured out how to live longer and almost double that, right? Our I would say average lifespan is in our late 70s to 80s. And so we're living, at least half our life, sometimes more for some people, in a less than ideal hormonal environment. And so, yes, technically menopause happens and our hormones go away, but they have such great value, not just from a symptom perspective, but from a preventative medicine perspective as well. And you think about, if hormones were bad for us, then we'd be screening all these 18 and 20-year-old people for breast cancer and heart disease and all these things, and those don't happen when we're young. What happens when you turn 50 is you get this list of all the things you need to start looking for now, right? You got to go have your colonoscopy, and you have to have a bone density test, and you have to have some screenings for cancers, mammograms, pap smears we do all the time, but that's a whole nother story. But so the point is that, yes, our hormones decline, but what we start to see in the decline of hormones is actually an increase in cardiovascular disease, an increase in bone loss in women particularly, which can be devastating. So there's a huge mortality associated with breaking a hip and fractures in women, but also in men as well. So, we're not doing anybody any good to just say, oh, it's natural to go through menopause and not have any hormones, or just treat it, to deal with the symptoms. So what happens is, as our hormones start to decline, the change in the hormones from normal to low will create what we call hormone related symptoms. Those receptors are going, hey, where did my hormones go? I want them back. And so it will send signals like hot flashes, irritability. We see decreased libido, we see painful intercourse or vaginal dryness, we see insomnia. I slept great, and then all of a sudden my hormones change and I'm not sleeping well. That can be stress related as well as hormone related. But again, we talked earlier about how all those are interconnected, right? We see weight frustration. So people say, I used to be able to make a quick change to my diet. I'd lose 10 pounds, easy peasy. And now, I'm doing everything right and I can't seem to get this weight off. So we get that menopause middle, if you want to call it. Increase in inflammation. So we see more people just kind of with the aches and pains, more diagnoses of arthritis as we age. And there are other factors as well in terms of, our diet. We talked about a little bit earlier and how that can increase inflammation, but hormones play a huge role in that. So we see improvements in these areas where there are studies that show us, the increased risk of cardiovascular disease as the hormones go down. And then the opposite of that, as we replace hormones, the benefits that we see, far outweigh what little risk is there. And we can dive into that a little bit. Why is that risk there, or the perceived risk of hormone replacement came 25 years ago, where there was a study done by the Women's Health Initiative for medications called Premarin and Prempro, and those were synthetic medications designed to use for hormone replacement. And really, even back then, it wasn't so much to treat hot flashes, but it was actually preventative for bone loss. So even my grandmother, who died when she was 89, she was on Premarin to help, protect her bones. And that she told me that. She said, my doctor has me on a hormone pill to protect my bones so that I don't have, osteoporosis and bone fracture. So we knew that there were benefits, from a preventative standpoint to hormones, but Premarin and Prempro are synthetic hormones made from pregnant mare's urine, and prometrium, which is a very, synthetic progesterone. And so they were doing a study in the Women's Health Initiative about hormone replacement and any risks. And the study actually ended early because they saw a significant increased risk of strokes, an increased risk of breast cancers, particularly. Both of those were like 200% higher than placebo. So they decided that study needed to be stopped early. And because it was one particular type of medication, or two, if you want to think about the Premarin and the Prempro, which was Premarin with progesterone mixed together, or the progestin, that then got everybody kind of in a tizzy, and it put a big umbrella on all hormones are bad. And when now, there's more and more evidence, people doing studies on more natural hormones, if you want to call it, or bioidentical, just using the estradiol or the progesterone by itself or testosterone by itself, and not using these synthetics, that we're seeing the opposite actually in terms of improvement in those things. So not only are we seeing the benefit of the bone health still, but we're actually seeing less risk for cardiovascular disease, less risk for breast cancer in patients who are taking bioidentical hormone replacement or topical hormones. It's also how you do it. So Premarin and Prempro were pills that you took by mouth. Those had to go through your liver, and they were metabolized very differently than now. We're usually using more topical dosing. So we're either putting it into like a cream, or you've seen estrogen patches that people wear. Men are getting testosterone replacement topically or by injection. There's no pill to take testosterone that is safe. So the way you do hormone replacement in terms of how it's delivered, in my opinion, measuring before, measuring, regularly throughout to make sure that we're staying in the right balance. All those things are super important to optimize and get the benefits of the hormone replacement without any of these risks that are still floating around there.
So hormones are also, don't they kind of counterbalance each other? And so is it important that you give them together? Um,
Yes.
okay.
So, one, I just think it's important to look at the big picture, right? So, you want to make sure like you have all the things that you might need. It's not just one thing. And a lot of times when I'm teaching this to other providers, I'm showing, hey, here's 3 different women in their 50s that all present with very similar symptoms, but yet when we look at their hormone tests, they're all very different. And so, one may need more estrogen, one may need more progesterone. And so it's an individualized thing. And there's so many different variables to what drives that. So just looking at someone and saying, oh, you're menopausal, you're having hot flashes. Do you have a uterus? Yes or no? Here's your pill, try that out, come back in 6 weeks. If you're still having some hot flashes, we'll just increase the dose. And that's really not the best way to do it, because we don't really know what those imbalances are and how much of each thing that you need. So it's really important to look at the whole picture and be able to balance them. If you're a female and you are doing hormone replacement with estrogen, then we need to make sure that we have progesterone on board. And I think, there's multiple reasons why we want to do this from a symptom perspective, but also what with the term is called unopposed estrogen. So if you're taking estrogen without any progesterone to balance it, that estrogen over time can stimulate the uterine lining or the breast tissue to grow more so than it should. And so it could potentially increase the risk of endometrial thickening, where you might have some bleeding issues postmenopausal, or maybe lead to endometrial cancer. We don't know, for sure. We don't say estrogen causes cancer, but it's that imbalance. And so you need, we call it the estrogen progesterone ratio. There's a balance there of the need for both of them to be there. Whether you've had a hysterectomy or not, I prescribe progesterone to everyone.
At a particular age, are you talking about when they're going through menopause or in general?
Well, particularly, I'm using that because, again, I kind of use the term, do you have a uterus? Yes or no. So it used to be that progesterone is only necessary if you have a uterus, just to protect that uterine lining. Otherwise, we would just give a woman estrogen replacement if you've had a hysterectomy for some reason. But my point is that there are progesterone receptors, which are those outlets all over your body, especially in your brain and in your heart. And so your brain is just wanting progesterone. You think about pregnancy, for instance. What do we talk about? Women who are pregnant, like in the middle of their pregnancy, not when they're first pregnant and puking or at the end and they feel like a whale, but right in the middle. Pregnant women are glowing, they're happy, their hair looks amazing, their skin looks amazing. That's all progesterone, right? So, if we go through menopause and we just don't use progesterone at all, or we just use estrogen, we're missing out on all those benefits of what progesterone can do for us in terms of our brain. That's what's going to help us sleep better. That's going to help your skin and your hair. And there's also receptors for progesterone in your heart. So we're going to see less high blood pressure issues and sort of, heart stress, if you want to call it.
So you spoke about, the brain needing this stuff. Does can a hormonal imbalance be either misdiagnosed or causal for things like dementia, Alzheimer's?
Absolutely. So there again are very strong studies that show a link between lack of estrogen and higher risk for dementia and cognitive decline. And not and it's all hormones really. So we see it with estrogen decline, we also see it with progesterone and even testosterone to some degree. And there's a very strong connection between um, progesterone and sort of what we call the neurotransmitters, so your dopamine and your serotonin and things like that. So they play a huge role in your mood as well. But definitely we are seeing concerns for hormone decline being associated with a higher risk of dementia. And there's actually a study that showed what we call the plaque, if you remember, or if you've ever heard of these plaques that form with Alzheimer's dementia in your brain, and so they get really sticky, and it doesn't let the neurons flow appropriately. That there is direct relationship between increased plaque development with low hormones.
That's kind of scary, isn't it?
It's very scary,
Yeah.
and we
How?
saw it for a long time. And I think when you start thinking about it, interestingly, when all women went off hormones 25 years ago, did we see an increase in, because women were taking all kinds of hormone replacement, not just Premarin or Prempro, but what happened is you know doctors got scared, women got scared, and so they went off all hormones. And you can see sort of the curves over the last 20 years of the increase in dementia diagnosis, the increase in cancer diagnoses when hormones went away.
So you or someone you love is menopausal. How do you navigate the storm? This is Mission Evolution, missionevolution.org. We're continuing our discussion with Dr. Aimee Duffy. Her website, carolinaintegrativeMedicine.com. Dr. Duffy, people, like I said, menopause has a really bad rap. And women, when they go into it, it's like if they're going into it from an imbalanced place and everything is in an uproar. What's your advice for them and their families to kind of weather the storm and figure it out?
I think there's enough new information out there that is disputing the scare of hormone replacement that was there. We were talking about 25 years ago from that Women's Health Initiative. So I think researching and it's tricky when you're just a layperson. You're going, how do I trust the information? But using some of these keywords like bioidentical hormone replacement or natural hormone replacement, if you want to think about it that way, and doing some searching on that will sort of reassure you to am I getting the right information. So one, I'm not saying that you need all the information, all the details and data to write your own hormone prescription necessarily, but to get confident that, hey, I need to find somebody who speaks this kind of language like we're talking about today. So finding someone who feels confident and comfortable that hormone replacement is a positive and a good thing, that's a good place to start. And then, what we're talking hormones today, and that's certainly my bread and butter, and where I started in this whole journey of what we call integrative or functional medicine. But we were dabbling a little bit in diet and the importance of, looking at the food that you're eating. And, it's really hard to tell somebody like what should I eat? What should my diet be? Because it really depends on what your goal is. So, we can talk about diets for weight loss, and we can talk about diets for detox, or anti-inflammatory diets that are out there. But to me, the simple version is, can we eat food that's as close to nature as possible? You can go pick an apple, preferably organic, and you eat it. And so there's like one step from picking it to putting it into your mouth, right? And so the more we can do fruits and vegetables, and you can cook your vegetables, so that's one more step, right? Meats, obviously, we're not eating a whole lot of those raw unless you want to have some, sushi or something like that. But yes, you want to cook your meat, and seasoning them is fine. But what happens is that we're eating foods that have 20 steps, from where they came from. Like, why does gluten get such a bad rap in bread and wheat and things like that? And I think one, it's been very genetically modified, but two, we don't go out and just pick a stalk of wheat from the wheat field and start chewing on it. It has to be processed, and it's dried, and it's ground up into flour. Well, even then, we're not eating spoonfuls of flour. It's got to be mixed and done all this stuff with it, and things put into it to make it rise and taste good. And then we have all these preservatives where, when we were younger, there was a bakery, and you would have fresh bread, and then you'd have the day old bread that was for a quarter back on the back shelf there, because even in one day it was old. Now we can go buy bread off the shelf in the grocery store, and it sits on our counter for 2 weeks and is still fresh as the day you bought it. And so that's chemicals. So it's not just about the gluten necessarily, but it's about, again, all the things that need to go into the process of putting food on our plate. And so, the easiest thing to me is just live in a world where it's, one or two steps to get from where it came from to how it's getting into your body. And you're probably going to be pretty darn good at that point. Then we can dig a little bit further. So in my practice, we actually do food sensitivity testing, so we can see, you might be reacting to spinach or to broccoli or to avocado or all these things that we know are superfoods and good foods for you, but for whatever reason, your body's reactive to that. Then we dig a little bit deeper. Well, why is my body reacting to that? What are the issues going on at the gut level that's responding to that? The other thing that I think is really important, particularly when we're talking about hormones, is that hormones don't cause any dysfunction in your liver, but they are metabolized through your liver. So if your liver is super busy worrying about all these chemicals that you're putting into it, it may not be metabolizing your hormones to the best of its ability. So we may see, too much being stored in different places. So making sure that our livers are prepared and ready. So, all these chemicals that we're either being exposed to voluntarily because we're choosing to eat and drink, chemicals and medications as part of that. Maybe not by choice, but we are, putting chemicals into our body. Um, there are some chemicals that we don't know, like, or we can't control, something that's in our environment, in our water, things like that. But what we can control, if we can minimize our body's exposure to those chemicals, and then, there's so many different ways to do it, but we take our patients through an easy detox to sort of bind those chemicals and get them out of storage and out of your liver, so that your liver can do the job that it was meant to do and help you metabolize things appropriately. So in my practice, we're not just focused on hormones, although there's a huge benefit to hormones for sure. Testing, seeing which hormones might be out of balance and the mixture that we need, retesting after you've been on them for a while so we can watch and see, and then regularly testing once a year once we find a maintenance place. But we're also addressing your food, we're addressing your gut, we're addressing toxins, we are addressing your mind and your stress management. So we started this whole conversation with dealing with the stressors of life. And so, we can say, oh, it's just stress, but really finding a way to help manage that. And what can I do to bring me back into that parasympathetic rest, digest, recovery place, so that my body is not constantly stressed out and trying to run from tigers.
So yeah, going through menopause will make you feel like you're running from a tiger, no doubt. So do you advocate organic food?
Oh, 100%. I mean, organic food is going to minimize our exposure to all those chemicals. And again, you may not notice it right away. If you go eat a strawberry that isn't organic, ooh, the strawberry tastes good. I'm happy, but over time, again, that accumulation of these toxins in our system, we were talking about weight gain a little bit and that menopausal middle. But another way that we see weight gain happen, and I see this in people who are like, I'm doing everything right. I'm eating nothing but chicken and broccoli. I'm getting my steps in and I'm exercising regularly, but nothing's happening. Well, again, our body's job is to protect us. And if we're being exposed by a lot of chemicals, the best storage unit for chemicals is fat. And so if our liver's busy and it can't get rid of these chemicals as fast as we're putting it in there, then it's going to create storage units. So we've heard about fatty liver disease, but you can also put more fat in other places. So that abdominal fat is more concerning because that's usually the fat that's storing all these toxins. So,
So if a person
we've got to
loses
get rid
weight,
of the chemicals.
if a person loses weight rapidly, do they run the risk of throwing all those chemicals back into their system?
They can to some degree, and a lot of times we'll have patients go through a detox, and you might see things like an increased risk of gallstones and things when somebody loses a lot of weight really fast. You can have headaches. You can have, they call it, you get like the keto flu sometimes when you change your diet pretty rapidly and you lose 10 pounds really fast. You may be releasing some of those toxins into your world. Again, our body's job is to protect us, so it's probably good to some degree because you're going to detox those. It may just be faster than you would have experienced otherwise.
The if you are doing a detox diet, to get a person back into good eating and that sort of thing,
Yeah.
do you find that the hormonal tests change a lot without changing without replacing hormones yet?
Yeah, to some degree you can see that again, especially in younger people when they're not quite menopausal, so we're not ready to just jump in and throw a lot of hormones their way. Let's see if we can, heal the gut, reduce the stress on their system, and go through that toxic load. You may actually, interestingly, hormones get stored in fat as well. So you may get like this a release of hormones, and so you can actually see an increase in hormones initially, and then it'll sort of work itself out over several months. Usually we'll see somewhere 3 to 6 months where you get this sort of, it's not high, but you can get a little surge of hormones and then they go back down again when somebody's toxic.
So like going into puberty all over again.
Yeah, yeah. I
That
think
wasn't fun the
sometimes
first
that's,
time. I think all
yeah, why people feel better, when they lose weight. They're not just feeling better because they lost weight, but a lot of people will say I have more energy, and that can be because we're getting rid of some toxins. It could be because our blood sugar is a little bit better balanced when we're eating healthier that way, and also we're metabolizing our hormones better, and they're not just going into storage. So we have kind of overall improvement everywhere when we get balanced with our weight appropriately.
So if you're dealing with someone, male or female, and they come into you and they're showing signs of major hormonal imbalance, um, do you start with diet, a test, and then start with diet and then test and then move to hormones, or do you hit them all at once?
It depends on the patient, but if they're in a woman, we talked about menopause being right around the age of 50 plus or minus, and men, same thing. Like if you're already in that menopause phase and your hormones are low, then I'm likely going to replace hormones because they're not going to come back naturally, even if we change diet and go through the detox. But we still will work on diet and detox for all the other benefits that we're going to see from that, as well as metabolizing our hormones better. So, in somebody who's already menopausal, I'll probably still start them on hormones. In a younger person, 20s or 30s, they may present with hormone symptoms, but I don't always jump right to hormone replacement. In that case, we would try to fix the underlying reason that the hormones are low in a young person when they shouldn't be low.
So do you see a difference then when you test hormones again? Do you see that adjustments are needed once they've done the detox?
Again, it depends on their age range. So in a 20-year-old, generally speaking, we can go through that process and actually see hormones regulate back to normal. Somebody in their late 30s, it depends on how long they've been there, whether they can rebound or whether, and for women, I'm talking specifically about progesterone. We see that progesterone decline happen. So it's not unusual for us to do progesterone replacement in a woman in their late 30s or early 40s and just decide, hey, this is going to be a long-term thing for you, that you'll be on progesterone, because the likelihood of it coming back up to a normal range that's going to be helpful is pretty low if they're there already.
Well, Dr. Duffy, I'm going to have to ask you, what is your mission?
Oh gosh, empowerment comes to mind. I mean, that's one of my favorite words. Is I want to empower people to have the freedom from this overwhelm of our symptoms. And I think, people get so helpless and hopeless that they think, oh, I've got this symptom, I'm going to have to live with it for the rest of my life, and I don't want to be on all these prescription medications, or they're on the prescription medications and they're taking them, but yet they still have the symptoms. And so, I really want people to understand all these things that we've been talking about. You don't have to know it again word for word to write your own prescription, but just to start thinking about the language and the conversations we're having, that hormones are safe, hormones are necessary, and they can really change your life if you do it the right way.
Well, unfortunately, we are out of time. Dr. Duffy, thank you so much for coming on the show.
Absolutely. Thank you for having me. This has been fantastic.
Our guest this hour has been Dr. Aimee Duffy, a renowned expert in functional hormonal health and the #1 best-selling author of Normal Doesn't Have Side Effects. To find out more about Dr. Duffy, where you can find her books and all she has to offer, visit her website, carolinaintegrativemedicine.com. This has been Mission Evolution with Gwilda Wiyaka. For more information or to enjoy past archived episodes, visit www.missionevolution.org. But please be sure to join us again right here on Voice of Canada Broadcast Network, vocbn.ca, where this mission will continue, bringing information, resources, and support to our evolving world.